All right. Hi, everybody. Welcome to Working with EHRs and Health Systems. I'm Paige Goodhew from Customer Success. It's right on the dot at 2 o'clock right now, but we're going to give a little bit more time, probably another minute or two for folks to show up. We've got quite a few that had registered for the event, so we want to make sure to give time for folks to get here. In the meantime, if you haven't had a chance to explore Crowdcast yet, you can ask questions. If you scroll down, you should see an orange box that says ask a question or suggest a topic. We'll be keeping an eye on those throughout the presentation today, and we'll be trying to address as many of those as we can at the end. If your questions don't get answered, or if you have some additional ones, there is also a button for you to schedule a follow-up call with one of our Redox staff. So feel free to use that too. As I said, we're going to give folks another minute or two, and then we'll get started.
I feel like we should just do like stand up for a second. I can introduce. So I'll just introduce myself as well as we're getting this started. So everybody, I'm George. Maybe some of you have spoken with me. I lead up a lot of our marketing efforts here and talk with a lot of groups to do solution matching early on, always with the goal of getting people to kicking off a project with Paige. So really appreciate you guys taking the time to join the webinar today. We hope it's informative to people, trying to make sense of the landscape that is all these various EHRs and what does it mean to create a solution that works with all of them, and how can we fit in. This came about from, we've been bringing on some newer employees for various roles, and people who haven't been in healthcare their entire career. It's really important to help them get a lay of the land. So we brought on some DevOps folks and front end developers who really talented, really great fits for the team. But those are the first couple hires away from just these ex-Epic, ex-healthcare people, and we realized how much is not known, how much is misunderstood, and I think this is a really neat opportunity to just kind of get a lay of the land. And I don't know if Paige mentioned it, but I mean, you've worked at Seattle Children's, you worked at Epic, now you're leading implementations for Redox. So I really think it's neat, her point of view, where she's been sitting at a registration desk at a clinic and in high school and in other roles in health systems, and then moving to those types of large scale project management of an enterprise electronic health record, watching that change of health systems, and now in her role today helping bring in these really great solutions covering all facets of the provider patient experience. So with that, I think we'll probably get ready to get going, and I'll be in the chat window, so ask questions if you need any support in the middle of the webinar as Paige is going through her slides. I'll be able to support that, and yeah.
All right, cool. Thanks, George. As George mentioned, I'm kind of a healthcare nerd. That's my background and why I'm here at Redox. I've been in the industry for 14 years now. Variety of roles, from doing registration, scheduling, patient care work, and all of that ultimately led me to be at Epic. I spent 6 years at Epic, working primarily on the inpatient product. And my last 3 years at Epic, I also crossed over into the ambulatory or outpatient product as well, with a high focus on how physicians were using the system, how to train them, how to make sure that they could effectively adopt it. So definitely have a lot of experience there, and I'm excited to share some of my knowledge, some of my thoughts about the industry and EHRs with you. One thing I will say to start everything off, this is fairly basic because I wanted to make sure we were all starting from the same knowledge point, but leverage the chat window for sure. This is for you guys. This is the first time we've done this webinar, so definitely interested in questions and feedback that you have about the type of content you would want to hear with this. But my goal is to make sure that you guys can all walk away understanding where EHRs came from and why they're so popular and why they're so important, and then some of the nuances of working with health systems and some of the challenges that you may already be facing as you're going through your sales cycle today. With that being said, too, I also won't go a ton into how Redox works with those. Follow-up calls are definitely good for that. I'll try to highlight a few of the things that we've learned or that we know about some of the EHRs, et cetera. But just want to make sure to set expectations from the get-go. And with that, I'm going to go ahead and share my screen and pull up my PowerPoint presentation. All right. So we're starting here with working with EHRs and health systems, and we'll go ahead and just jump right into things. So EHRs are a pretty interesting thing. If somebody had told me back when I graduated college that I would be working in IT and healthcare, I wouldn't have believed it. My original goal was to do administration at a hospital. But the main reason why I would have never pictured this is because there was a huge change that came to the industry in 2009 with the HITECH Act. This was passed by the Obama administration and designed to really encourage the use and implementation of electronic health records, or EHRs, at U.S. health systems. The main reason for this, as most of you probably are aware, is that the U.S. health system has an interesting honor of being one of the most expensive systems in the world, but still not the best in terms of care. So the goal was to leverage the technologies that were available to improve that care that we're providing, as well as get a better understanding of what it is that we're doing in the U.S. that is making our healthcare not the same quality that it could be with some other standards. This HITECH Act of 2009 introduced a concept that you guys may have heard of called meaningful use. So what is meaningful use? This is actually, I think, straight from the Meaningful Use Wiki. So this basically is the idea that a certified EHR is being used in a meaningful manner. The example here is e-prescribing. Other common examples are electronic ordering, electronic notes, et cetera. Basically saying that, that a health system is leveraging the technology that's available with that EHR. Secondly, using that EHR technology for electronic exchange of health information is really important. That's definitely a big piece about where Redox comes in. And the last one is using that technology to submit clinical quality and other measures. So meaningful use is really the cornerstone of the HITECH Act and how health systems are being evaluated to see how well they are meeting these goals. The evaluation is in 3 stages. So there's a 3-stage rollout that was announced, I believe it was a part of the act. If not, it was shortly after. And the goal was that all of this was supposed to be implemented by 2017. Stage 1 was happening in 2011 and 2012. And that was really focused on data capture and sharing of information. Stage 2, which began in 2014, is to advance clinical processes. And stage 3 is technically supposed to be starting this year, but as you can see here, the proposed rule was actually just released on March 20th. So there's some doubt that it will actually go into play this year. But the focus on this one is improved outcomes. So this is really what the government was going for when they introduced this act. The other side of this is the way that the government rolled this out with the different stages is they used a process of carrots and sticks is the way that I always think about it. So starting immediately, health systems that were showing that they were meeting meaningful use were receiving an incentive of increased reimbursements for Medicare patients. As you may or may not be aware, the majority of healthcare expenditures or payments come from Medicare. So that was a pretty big incentive to offer to health systems, is that if they got this EHR installed, that they would see higher payments for that. Starting, I believe it starts in 2016, it now becomes a little bit more of a stick or a penalty. So we're now starting to get into the stage where for health systems that haven't installed and shown that they are meaningfully using an EHR, they're now facing penalties in the form of reduced reimbursements for those Medicare patients. And so that's really how this was implemented and why this became such a big deal for so many health systems to implement. What we saw, this graph here is from 2015, is that because of this, you can see a pretty steep rise in the use of EHRs. And the numbers in 2015 showed, depending on who you ask, this one has 84%. I've also heard estimates in the 90s of hospital health systems that are using EHRs. So this definitely was a huge factor and encouraged health systems to get this installed. Practices and independent practices are a little bit different. They do still have a fairly high rate of adoption, but as many of you may have encountered in your sales process, some of those smaller physician practices, those 1 to 5 or 10 physician practices, have definitely struggled with being able to meet this. So that's kind of the background about why this came to be and where this trajectory came from. I'm sure a lot of you recognize that this was a cornerstone of where your applications and products have come from as well. All right, so these were the meaningful use goals that were set when it was initiated. And you can see that this is really what what the government was trying to go for. In 2013, HIMSS released this infographic that I thought was pretty interesting to show really what is the value of health IT that we're seeing so far now that we're a few years into meaningful use. So you can see here up at the top, STEPS is where they ended up with it. I'm curious as to how long it took them to figure out the right acronym for it. But you can see here at the top, one of the big things that they've seen is that there is increased satisfaction for both patients as well as staff in using health IT. I think that there are some people that might argue that this is truly the case, but in my experience, the vast majority of physicians that I worked with appreciated a lot of the benefits that came from an EMR, while still working through some of the struggles that came from making that change. The next one, the T, is that treatment. This is one that I personally think is really neat. It is a really great opportunity for us to be able to really see the effectiveness of the treatments that we're using with patients and to make sure that we're always using the most effective treatments and tracking it appropriately. After that is the electronic information and data. That's really the heart of an EHR, is that database that it provides. And the example they use here is related to claim denials, and that's just because being able to know whether or not a patient has had a certain test done within whatever the time frame might be for the insurance companies can reduce the likelihood of that test being ordered and not actually paid out for by the insurance. The other one, though, that I think and that I feel very personally attached to is I grew up in a day and age where my medical records as a child were all on a paper chart. I learned a few years ago when I was trying to collect some of my vaccine information that the state of Indiana, where I grew up, allows medical records to be destroyed after 7 years of inactivity. So I'm now sitting in a place where, because my information was on paper, I don't have access to my childhood immunization or my childhood information. And so thinking about today's children and those folks that or basically today's children, my little 1-year-old nephew, all of his whole life will be tracked electronically, and he'll always have access to it. And I think that's pretty cool to realize that huge value that's offered to us as patients, as well as the infinite possibilities when you think about longitudinal research and other types of things that can come from having that much data. The P there is for prevention and patient education. This is definitely something that is also really great to know, that we're able to leverage technology to help reduce human error, both in terms of care that's being given, as well as error from how patients are executing on their clinical treatment plans that were given to them. So you can see here, there's been a huge increase in scanning compliance for when patients are being given medications in hospitals. Back before EHRs were so prevalent, it actually was one of the leading causes of death in hospitals was incorrect medication administrations, and that could be to the wrong patient, the wrong dose, the wrong medication. So knowing that this IT that's been brought in has the ability to help reduce that error is definitely huge and a really important thing for U.S. healthcare. And then the last S there is the savings. I think this is something that we can all imagine would come from moving things electronically, but there is a high amount of savings that has been seen with this move. A lot of that is being able to eliminate other services that were being used, and that could be extraneous staff that's no longer needed. It also can show some savings in the reduction of errors. Once again, I think that there are some arguments to be made with the cost of implementing an EHR. Is there really that offset? But most of the data that's coming out and what health systems are saying is that they are actually seeing a much faster return on investment for installing that EHR, which is really great for us, especially as the U.S. is facing intense pressure to reduce our cost of healthcare, particularly as we look at the baby boomer generation tipping over into the age range where they will likely start needing more healthcare. So this was kind of where we are today and what we've gotten to. So what does that mean for the future? So there is this, and I've got some links here in the PowerPoint. We can share the PowerPoint afterwards if you're interested. But there is a federal health IT strategic plan that was released. It's available on healthit.gov. If you've never looked at that, I strongly recommend that website's got a lot of really great information. But in 2015, the government released their future vision for where they want health IT to go. And here you can see the 3 goals they have, actually 4 goals with that enhancement of the infrastructure that you see. But this is really where the government's hoping to move. In the industry, and I think that what a lot of folks are seeing is that in some cases, some of those initial goals for meaningful use in the HITECH Act and all of these things that have gone into play, we've partially met them, but we haven't wholly met them. So it's great that the government is pushing forward on setting new goals that we should be striving for, but there definitely are still areas that we're still trying to catch up with the technology, especially now that we've been using it for years. We have a much smarter base of users that know and understand what they want from an EHR. And that's where applications like what you guys do really come into play. You're able to help bridge that gap between what EHRs can and can't do, and how can we continue to augment these to be able to continue to meet those goals and push our health IT to the future. All right, so what is an EHR? So I would like to use an office space example here because I think EHR can feel like a really nebulous term to hear. And part of that is it's used a little bit as a catch-all. So your EHR is your electronic health record. There's a lot of different ones out there, and in a little bit I'm going to go into some of the major players in the space, but wanted to make sure that to kind of explain some of the nuances of when you're talking about an EHR or talking about wanting to integrate with an EHR, what does that really mean? So the first, as I kind of mentioned, an EHR is really the central nervous system for the IT infrastructure at a health system. The EHR is generally the central repository that's used. Oftentimes, it's going to have a mix of clinical data as well as practice management style data, which I'll talk about in a little bit, to help paint that picture of both the patient's clinical needs as well as the patient's demographics and billing information that's available. But it's really that hub for the health system. Oftentimes the EHR, being that central repository, is what's used as the source of truth when there are additional systems that come into play. And I'll talk a little bit about those different types of systems here. So I mentioned that there are clinical systems. So your clinical system is going to be anything that's used by a doctor, a nurse, a therapist, et cetera. These are really focused on capturing the care that's been given to the patient, the medications that they have been prescribed, documenting their problems, et cetera. Within clinical systems, you also do run into niche systems. So when you think about the Epics and the Cerners of the world, those have the clinical, those are essentially primarily known for their clinical capabilities, but there are sometimes niche systems that are used to augment those. So some common examples that I see that aren't really in the Epic and Cerner space that much right now: radiation oncology systems, neonatal systems. You also might run into some lab systems or radiology systems. So while the EHR might be that central repository, there may be other systems that are on top of it that are really designed to be used in very specific areas and very specific places. Practice management, I alluded to this, but practice management systems are generally defined as the systems that do, I think about it as your patient access and your scheduling and your billing side of things. So the clinical systems focus on the care the patient's receiving. Practice management is focused more on what is it that we need to keep our practice running and to make sure that we're generating the revenue that we need and are able to get patients into the system. I also put on here the OP versus IP, or outpatient, also known as ambulatory versus inpatient or acute care. Your outpatient or ambulatory sites are focused on primary care, walking in and out of the clinic type of visits, and inpatient are your hospital systems. Once again, some of your big players have both of these, but some of your smaller players, so Athena is a great example. Athena actually currently only has on the market outpatient style systems. They don't have something for use in hospitals at this point. So there definitely are some nuances and differences there. As you are looking at the customers that you want to work with, the health systems, and as you're talking with them about their systems, I strongly encourage you to kind of think through what are the types of systems that we need to be talking with. What's the data that we need to receive? While across the U.S., many health systems have moved to a single EHR where they can. There definitely are still systems that might use one vendor for their practice management system and another vendor for their clinical system. So there definitely are some nuances that you may run into as you're working through the sales process and talking to health systems, and definitely something that we'll run into when we do integration. And then the last thing for what an EHR is used for, it's really used for a lot of those core workflows and the key users at the health system. So obviously on the clinical side, your core users, like I mentioned, are your physicians and your nurses, or pardon me, your key users. Those clinicians that are really actually giving and providing care and need to be able to document it. EHRs are really good for covering things that need to happen every time. So if you're in an outpatient visit, you need to make sure that the patient has a visit diagnosis documented, that they have a note that's been written, need to make sure that any orders that were queued up have been signed, et cetera. EHRs can really help with tracking those types of things and are really designed for those key users. Now, one thing where EHRs sometimes do stumble and fall are some of those things that are outside of core workflows. And that could be in the form of really specialty specific things that are needed. I know one of the areas that we've seen a fair amount of applications reach out to us for help with is in the telehealth space and patient reported outcomes. And some of those other areas where it's not a part of the key workflow that keeps the clinic running, but it definitely is key information that can, or key services that can be provided to make sure that your patients are engaged appropriately and that you're getting the data that you need from them. So that's really where there's a nice gap that applications are starting to fill right now, and is pretty neat to see. If I had to make my future prediction for 2050 or 2060, I'd say that, we're really moving to a space where the EHR will be that core database and we'll likely have a lot of that core information. But I think that there will be a lot more movement in the future towards different physicians and specialties and different roles being able to use applications or other systems that were specifically designed with them, rather than having to try to fit a square peg into a round hole. So it's definitely a really exciting time in the industry right now. And you guys are doing and leading that cutting edge, which is really neat. And we're thrilled to be able to help support you with that. All right. So we're going to talk next about the players in the EHR space. Likely you're familiar with several of these. So the graph that I have here comes from a body called CLASS. This one, I might need to check to update this because I know that there was a Siemens and Cerner merger last year, I believe. So this needs a little bit of updating. I'm not sure if CLASS has released for this year yet or not. But CLASS is an independent entity that really tries to go through and rank and provide data on how well different vendors are doing in the healthcare IT space. They do cover EHRs, but they also cover things like medical devices, consulting groups, et cetera. Before I jump into the graph to explain, over here on the left is really referring to the type of practice. So right down here in this bottom quadrant, you've got your independents. So this refers generally to your small physician practices, maybe some independent standalone ambulatory surgery centers, but basically health system or health facilities that are not affiliated or integrated as a part of a large network. Up here at the top, you have your IDNs, which are your integrated delivery networks. And these are your big healthcare systems that really cover the gamut of outpatient care to inpatient care. A lot of these would be, here locally in Madison where we're based, we've got UW Health, so the University of Wisconsin Health System. We have Meritor, we have Unity Point. So a lot of those systems that can cover everything from start to finish. Down here on the bottom where you see best of breed and enterprise, this is referring more to the EHRs themselves. So best of breed refers to EHRs that provide very specific services or very specific areas of expertise. Enterprise focuses on EHRs that try to offer the breadth of services that are available. Down here too, you can see I've got some other links that you can check out later, but we've got things to know about the different EHR vendors. If you don't want to wait for this, it's the Becker Hospital Review article. It's called 50 Things to Know About Major EHR Vendors. Kind of an interesting read to start to understand a little bit more about the space. I'm going to dive into 4 of these. So I'm going to talk about Epic, Cerner, Athena, and eClinicalWorks. I'm covering the 4 of these because these are the ones that we're seeing pop up the most. You may have encountered some other ones, and we do work with any EHR that's out there, but had to stop it at some point. So I'll start by talking about Epic. So Epic is really the most prevalent player in the market space today. On last estimates that I heard, based on what they hear from their customers, about 56% of the US population is touched by Epic in some way. So pretty impressive for a company that started in 1979 out of Madison here. They're really the big player, and they are unique in that their system is it's actually fully designed within Epic. Some of the other players tend to do acquisitions. Like I mentioned, Cerner acquired Siemens recently, whereas Epic is really focused on if they want to go into a new product or new space, they'll do all the development in-house. And what this means is that they really, at its heart, have this one patient, one record idea that they feel is very important to reduce the need to interface within its own Epic system, which you sometimes see when you're talking about all the acquisitions that have occurred with some of the other vendors out there. Epic, I think of Epic as kind of like the Apple of the EHR world. It's definitely one that overall has a good reputation in terms of the software that it provides, has a focus on aesthetics, tries to push that boundary, and really is seen in a lot of ways as one of the best systems, or as the best system to have. Where Epic, though, is also similar to Apple is that they are want to have a lot of control over what does and what touches their system. So just like Apple makes sure that any application that's in the iTunes store, that they've been able to approve it, Epic feels the same way. And oftentimes it's garnered them a reputation of being a very closed system and a system that's difficult to be able to integrate with. So that's where they're a little bit unique in that sense. And they are, very proprietary about working with their system. They did, I think it was 2 years ago, released open.epic, which some of you may be familiar with. And this is really their opportunity or their way of trying to make it easier for applications to be able to integrate with them. So it's definitely a neat option that's there, and great that they're trying to open their system, but they're definitely doing it in their Epic way, where they've got a lot of control over it. One other thing to note about open.epic, or just working with Epic in general, Epic is very focused on what their customers want. They are privately held. That is actually one of the other differentiators for them compared to the others on this chart here. But that means that they don't have any other interests except for the customers that have paid for them. And so that means if you are, hoping to get something into Epic or want something that requires software configuration changes, odds are Epic is not going to talk with you as an application. But if you can get a health system to request it, that's when Epic will listen. And so just kind of a little word of advice of working with Epic. The key to getting through to them is definitely having their own customers requesting it. The next one here is Cerner. Cerner is the second biggest in the space, and Cerner actually has a much larger presence internationally. Epic has international presence, but not on the scale of Cerner at this point. Cerner, I'd say, is one that is, compared to Epic's perception of being a very closed system, Cerner is very focused on wanting to lead the way on different types of initiatives in the industry. And, one example of that is they were one of the founding EHRs, or one of the founding vendors for Commonwealth, which is an alliance that's pledged towards interoperability. So pretty neat that they were one of the first to realize that instead of, that the EHR vendors themselves needed to have a response to the claims against the challenges of interoperating. So Cerner formed Commonwealth with McKesson and several of the other vendors, and used it as a platform to say, look, we're trying to work on this. We're pledging to figure out a way to do this better. I think that was back in 2012, if I'm remembering correctly. Epic, there were some interesting political plays there. Epic is a partner in a similar one called Healthy Way. So there's some interesting stuff there. If you're looking for some literature on the politics between Cerner and Epic, that's an interesting one to see. But Cerner definitely really wants to push those things. The other thing that is that I'd say Cerner is synonymous with in the industry is FHIR, or FHIR, which is the updated HL7 standard that has definitely been the buzz. And the claim with FHIR is that it will make it much easier to interoperate between systems. To date, we haven't really heard any requests of FHIR and haven't seen that manifest itself in many tangible ways. But I would hedge my bets to say that when FHIR does come, Cerner is definitely going to be leading the pack on that. It's something that they're very focused on, and that they are trying to do as much as they can with it. They have a really large FHIR shop with Intermountain, which is a large healthcare system, and are working very closely to do that. So there's development that's happening against FHIR. It's definitely out there. It's available. It just hasn't caught on quite yet. The next one I'll talk about is Athena Health. So Athena is an interesting one because they kind of came out of left field and surprised Epic and Cerner a few years ago. They were one that I think a lot of people thought wasn't going to quite catch on, but they really have started to and have gotten a lot of attention. Athena was one of the first to really push the idea of a cloud-based EHR, and that's really their claim to fame and the thing that's definitely been their biggest differentiator. Epic and Cerner, on the other hand, typically when they're installed at health systems, they are installed on-premise. So that means the health system installs the software on their servers. They have staff at the health system that are building and maintaining it. And really the work of getting that EHR set up and configured and maintained does fall to the health system. Athena's cloud option offers a chance to implement more quickly, because being cloud-based, they can push it out in a faster manner. You don't have to worry about buying servers and making sure you got the staff to maintain the servers and the EHR. So that was really what their push was. Additionally, from a maintenance standpoint, being cloud-based, that means that Athena is able to push out things like annual updates or even interim updates to all of their customers without needing their customers to be heavily involved, which is different from the on-premise way that Epic and Cerner is typically installed. Interestingly enough, Epic did recently start doing hosting as an option for customers. I don't think that they're live with any customers that are hosted yet, but that is an area where Epic has started dabbling. But for the most part, when you hear Athena, it's going to be cloud-based, and when you hear Epic and Cerner, it's going to be on-premise. I think of Athena a little bit as a disruptor in the industry. Jonathan Bush, who's their CEO, is a very interesting man. He's got some really great ideas. He's a little wacky in some ways, but he really is trying to push the envelope and push things in the industry out of its comfort zone and into the next level, which is pretty neat to see. Athena has something which several of you may be aware of and may be involved in, called More Disruption Please, or MDP. I think of that as kind of their version of Open.Epic. So both Open.Epic and MDP are great platforms to do development against and to work with. The caveat with those being that you're only building against Athena or only building against Epic. And that's where Redox is here to help you guys be able to build once and connect to any of the EHRs that you want. The other thing with Athena, as I mentioned earlier, but just as important to note, is that they currently, in terms of product offerings, do only have stuff in the ambulatory space. Rumor on the street is that they are looking to expand into the inpatient space and are hoping to have a product release in the next few years, but just something for you guys to be aware of and to think about as you're talking with customers. If you're hearing or thinking that you're using Athena in the hospital setting, that's probably not exactly what's being used. So definitely something you can dig into if you've heard that. And the last one I'll talk about is eClinicalWorks. eClinicalWorks is another one that is typically, I'm going to say typically because they're not always, but more often than not, they're also hosted, health systems EHRs are hosted by eClinicalWorks. So eClinicalWorks is doing that management. Between eClinicalWorks and Allscripts, they're definitely the favorite among those small physician practices, like I mentioned. eClinicalWorks is a much lower cost health system, or a much lower cost EHR for health systems to implement, which is a big reason why they've really caught on in those independent and small practice markets. But while they're low cost to implement, there are usually additional costs that come down the line when there are system changes that need to be made. So one of the biggest things that I would say for everybody to be aware of, if you're working with a health system or talking to a health system that uses eClinicalWorks, odds are that there are going to be additional fees that the health system has to pay in order to do any sort of integration with eClinicalWorks. And that would include if a Redox connection that's there. Something that I just always like to point out to folks to make sure that you're aware of that. It also can take a little bit of time for eClinicalWorks to be able to prioritize the project and get it there. So if you are working with health systems that use eClinicalWorks, you're probably looking at a few more weeks of time that the health system needs to spend with eClinicalWorks before the project can fully kick off to make sure that all those connections can be there and that the health system understands what the cost implications are for them. So those are the major players in the healthcare space. You've likely may have encountered some of these, or if you haven't gotten out into the sales field yet, you will encounter them. So hopefully that gives you a little bit of a high-level overview. I also had these, I talked about some of these other ones earlier, but just to cover them. So there are other types of health information systems. And this is where it starts to get a little interesting, because some of these could be a part of the larger EHRs, or they could be standalone. And I apologize for my typo on the slide, but that first one is Laboratory Information System, often referred to as an LIS. So Epic has one of these called Beaker, but there are also some other standalone laboratory information systems, such as Orchard. So something to just be aware of, if you have an application that's really focused on getting information from lab systems, you may need to just be interfacing directly with the health system's lab system, which may or may not be the same as their EHR. Similarly, there's the Radiology Information System, or the RIS, the RIS, where the other thing to note about these two is these are the systems that are used in the lab or in the imaging areas by the techs that are actually performing the diagnostic procedures. Typically, this is they're receiving, or orders are being entered into these, and results are being generated from them. So they're definitely very specialty areas, and that's why we still do see a fair amount of independent players outside of the big guys that have this space captured. Another health information system you may have heard of is a PACS. This stands for some long word about, I can't remember what it is, I looked it up, but everybody refers to it as a PACS system. This is essentially how radiology films can be shown electronically, so that physicians no longer have to go look for a backlit wall or a light bulb to hold the film in front of. These can be shown electronically here. And earlier, I also mentioned those niche systems. So radiation oncology and neonatal are two that I've definitely run into a fair amount. But there's a whole variety of systems that may be in play. So I would encourage you, as you're identifying what it is that you need to talk to health systems about or what you need to ask, think about, where would you expect the information that your application needs to come from, and ask the health system a little bit about what their systems look like and which ones they're using. All right, so this is actually one of my favorite slides to put together. I'm going to talk a little bit about the different types of health systems and some of the things that we've learned about working with them. These are actually all health systems that I've worked with at some point in my career, so that's why it was definitely a fun one to put together, but also helped me to remember what it was that I wanted to talk to all of you guys about with each of these. So I'm going to start up in the corner with UC Health. This is the University of Cincinnati. This represents an academic medical center, or an AMC. Academic medical centers tend to be the ones that you hear about. These are the Dukes of the world, the Mayos, the Cleveland Clinics, a lot of those big ones that are affiliated with universities. They are part of the reason why they are your marquee customers are because they are likely the ones that are pushing the envelope in the medical field. They're doing the research, they're putting out the studies, they're trying new things, and they do a lot of really cool and really great things. Your typical academic medical center really is going to cover the gamut of services for a patient. So it will cover outpatient services as well as inpatient services, but it will also cover a huge breadth of different specialties. So odds are if you need to work with someone who is a pediatric rheumatologist, which is very specialized, they're probably affiliated with some sort of an academic medical center. So they're really great customers, and they're definitely ones to get excited about having the opportunity to work with. One of the things that we have seen with academic medical centers or any of your really large networks, they tend to move much, much slower. And that generally comes down to their willingness to take on risk. And it's kind of interesting because it's a little bit of a dichotomy that they are the innovators in the clinical space, but they tend to be a little more reticent to take on risk in terms of how it might impact their business. And some of that is because of the scale that you're talking about when you are making changes. So like a typical academic medical center hospital is probably anywhere from 500 to 1,000 beds. So you can imagine the amount of staff that it takes to run that. So bringing in and introducing new systems or applications can really rock the boat. So something I would say, I definitely would be excited when you're talking to these guys, but keep in mind that there's likely additional layers of red tape and approval processes, and a lot of other factors that go into how quickly you'll be able to move with these groups. And that leads me into down in the lower left-hand corner, I've got North Oaks Health System as my example of a community medical center. This is a little hospital down in Louisiana that I worked with for a few years when I was at Epic. And they, to contrast that academic medical center that had, I mentioned 500 to 1,000 beds, their hospital, I think it was 25 beds. So much, much smaller scale that's there. Community medical centers, the biggest differentiator for them is they usually provide a much smaller range of services that are designed to focus on the primary things that are needed on a regular basis in the community. So oftentimes, they'll obviously have primary care. Orthopedic care is a really common one that you'll see at community medical centers. Dermatology, usually there's OBGYN services, et cetera. But you're not going to see things likely like oncology may not exist at a community medical center, neonatal intensive care units. Some of those other really specific pieces may not be there. So that's where they're different. It gets a little murky because an academic medical center may have affiliated community hospitals. So like I mentioned, UC Health that I worked with, they obviously have their flagship university hospital, but they also had a community medical center called Westchester that they were affiliated with. So there's a few nuances about how they all interact, but definitely important to call out. Community medical centers, one of the things that we've seen, these do tend to move pretty fast. They generally, because of the smaller amount of services and just the amount that their IT team is supporting, usually can move much quicker. In my experience, they haven't had quite as many checks and balances or processes to go through to get your project approved. So just something to note, when you're looking at your pipeline, I think it's easy to want to overlook some of those small places, but if your goal is to get your application live at as many places as possible quickly, it may be worth taking a second look at those community medical centers, because they're likely going to move faster and get you some real experience with your product and some changes before you start to take on some of the big boys. Over in the top right-hand corner, we've got Seattle Children's. This is my example of a pediatric hospital. Pediatric hospitals are obviously focused on kids, and they are a little bit unique in the sense that the care that's happening there is, well, it's the same as obviously adult medicine, in which you're trying to get a patient better, but it has an interesting nuance of trying to make sure that the treatments that you are using for your patient aren't going to do anything that will impact their mental, physical, or emotional development, because they're still going through all of that. They tend to, have people that are really, they're kind of interesting in terms of the people that work at the different types of healthcare systems too. I'll try not to go too far into this because that's my one of my psychology things coming out. But I find that pediatric healthcare systems, more so than others, are really focused on wanting to move fast and doing as much as they can for their patients. They just generally have a lot more urgency around what they're doing. So it's kind of an interesting thing to see. They may or may not also be associated with academic medical centers. So Seattle Children's is actually considered the pediatric arm of the University of Washington. They're just down the street from one another. But what that means, though, is that the University of Washington, at their medical center, they actually very rarely will admit pediatric patients there, because they will send them down the street to Seattle Children's, to that pediatric specific facility. UC Health has something similar with Cincinnati Children's, which is right down the street as well. So kind of some interesting ways in which those systems all work together. My next example, so Samaritan Health Services, I called out here. They are located in Corvallis, Oregon, and they're my reminder to talk about inpatient versus outpatient, which we talked about a little bit earlier. But one of the things to think about is sometimes you have health systems that truly only have outpatient offerings and may have an association or affiliation with a hospital. And sometimes you have standalone hospitals. So as you're approaching your customers or thinking about which customers you want to talk to, think about, what is your market? Is your application used best in hospitals? Is it used best in clinics? Is it used best when it can go between the two, or when information from the two can be shared? Definitely something to consider as you're figuring out which health systems you want to talk to and how to frame your value propositions for them. ORA Orthopedics is an example of a specialty organization. So the name kind of gives it away, but ORA only does orthopedics. It's a set of clinics located over in the Quad Cities in Iowa, and they are focused on orthopedic care. This is another one that depending on what your application does, it's interesting to and I would consider targeting organizations that do just the specialty that you're going to provide the biggest benefit for. Similar to those community medical centers, we find that these small specialty areas can move very quickly. And that's because, if everybody at the organization does orthopedics and there's a solution that's going to improve orthopedic outcomes, it's a pretty easy decision to want to move forward with it. And also that impact, once a decision's made, is pretty great and impacts everybody that's there. So there's usually, the right amount of pressure to get things moving. And the Memorial Hermann down here is my example of an accountable care organization, or an ACO. ACOs are one of the big things that's happening in the industry right now, and has actually ended up with a lot of mergers and acquisitions in the healthcare space. If you've been paying attention to probably the past 3 years or so, you've probably noticed there's been a lot more of those in the industry than we've seen previously. But accountable care organization, the idea behind that is really forcing organizations, healthcare systems, to look at the continuity of care for the patient. So, outside of an accountable care organization, it's not uncommon that you have a patient that goes to a hospital for pneumonia. The hospital is really focused on getting the patient well enough to go home. And then they're expecting that the patient's primary care physician will pick up their care once that they've been discharged. And that sometimes happens, sometimes doesn't. A lot of it depends on those relationships between the hospital and the clinic and how well that's communicated. The idea of an accountable care organization really links together that outpatient and inpatient care. It can have implications to even home care as well. And is really trying to hold the organization accountable to say, okay, hospital, it's not just your responsibility to get the patient well enough to go home. You also have responsibility to make sure that you're communicating effectively with the patient's primary physician on what the treatment should be. Maybe you're even still doing some outreach with that patient. So it's definitely the big trend in healthcare right now, and trying to really force our systems to stop being so segmented and really be looking at the patient holistically. So that's just my overview of the various health systems. All right, so we've talked about a lot now, and hopefully you've picked up a few nuggets. The last thing I want to cover is just kind of who are you working with when you're at health systems, and who is it that you should be expecting to talk to, and what is it, how do you kind of break in and figure out what to do? So the first, I'm going to actually cover this in the scope of what are the challenges that you face when you're trying to get a health system on board with things. The first is your length of the buying decision. So some of you may have run into already. It takes a long time for health systems to make decisions for products to buy. I think the averages that I've heard is it's a 12 to 18 month sales cycle with health systems. So there's definitely a lot of work that goes into getting everybody that you need on board. And one of those first places where you actually start is that or maybe not start, but where you need to get to is that C-suite. This graph here I thought was kind of interesting because it shows that in healthcare, more than other industries, there's a large amount of engagement from the C-suite in making that decision about the change. And a big reason for this is that the C-suite feels a lot of responsibilities in healthcare systems for making sure that change is adopted. A lot of healthcare systems don't make a lot of money. And so any decision that's made that's going to cost the health system money really needs to be well thought out, and they need to make sure that they understand how it's going to be executed so that they can see that return on investment. So your C-suite at your health system, there's a few different ones you may or may not have talked to, but some of your most important ones, especially if you have a clinical product, are going to be your chief medical officer or your CMO, and or your chief medical information officer, your CMIO. These are typically, they're physicians. I think they almost always have an MD, and they're really the folks that are advocating and speaking towards what the clinical needs are. Now, depending on what your application does, you may also want to make sure that you get in front of a CNO or a chief nursing officer. And the chief nursing officer usually has domain over other ancillary services like respiratory therapy, physical therapy, et cetera. If not, there may be some managers or directors that they could pull in for products geared towards those. But it definitely is important to make sure that you've got that engagement from that high level. Hospitals really are top-down organizations for the most part. Now, how they distribute that changes a little bit per organization. Some that are more focused on lean principles really do encourage and try to generate making sure that people can implement changes at any level. But we see in healthcare that this is a really important person to get the sign off from. And even if you're not talking to them in those first calls, odds are it's going to have to go by them at some point. There usually are several layers of governance processes or governance committees that decisions like this need to be run through. So you may get your entry by talking to a manager or a director, but odds are there's some sort of process that will take it up to the C-suite eventually. Other C-suite people that you may interact with, your CIO, so your chief information officer is another one that may come into play. And depending on what your application does, the CFO, so your chief financial officer, may also need to be consulted with it. Another challenge is getting that champion support. So I've kind of alluded to this in terms of that engagement from the C-suite, but in order to really get through that governance process, you need somebody at the health system that's going to champion it and push it. Every health system has their different nuances. I worked with one recently that in order for us to get approval for the project, we had to go through 3 different committees. You would have never known that as an application. We wouldn't have known that, but the people at the health system that work there understand what the processes are. So it's really critical to have a champion that's willing to take your product through all those various phases. You really want that person to know how to explain your value props and the return on investment that you can offer so that they can help push that through. If you don't have a champion already at a health system, I'd encourage you to think about who your contacts are there, and talk with them and help make sure that they're educated about your product so they can push it through. I would also encourage you to have regular communication with those champions. They are great people to be able to pull in when projects get stuck, or when things don't seem to be moving. They may be really busy and it may take them a few days to get back to you, but they're really going to be your key to helping push things through this buying cycle that needs to happen before you can move on towards an actual project. And then that last challenge here is that IT prioritization. So oftentimes, or really at health systems, your IT department is supporting the whole system. And this really plays into a lot of why those academic medical centers and those large systems can be particularly challenging, is the IT team is balancing not only your project, but potentially 10 other similar projects, probably some improvement projects with their existing systems. They are maintaining and troubleshooting. They're providing support. They have a lot on their plate. And so that's where sometimes those smaller systems, their IT team has a little bit more balance. I remember talking with our chief customer officer here at Redox, and he was telling me about a conversation he had with a CIO at a health system who showed him a list and said, I have 60 projects on my plate that we've committed to, that we've bought, that we want to do. And he's like, and I'm adding anywhere from 5 to 10 additional projects every month that are getting added to this list. And the struggle right now is getting that prioritization aligned appropriately and getting and having the team that can do it. So this is definitely a challenge that comes up. This is one where Redox can help cut through some of those challenges. One of the things that sometimes when you talk about needing to integrate or needing data from the EHR that can throw up some hackles is the thought of, oh my gosh, we're going to have to do integration. And for most health systems, they think of that as a direct interface. Direct interfaces can take anywhere from 6 to 12 months to implement, and it's very time intensive on a health system. Redox offers an opportunity to make that much quicker and much lighter on their team. So definitely something to think about as you're positioning your product and the process of getting your product there. Think about, how do you make this as light as possible on the healthcare system? Odds are the lighter that you can make it for them, particularly their IT team, the more likely it is for your project to go higher up on that prioritization list and be able to get it done. All right. So that goes through my presentation. I'm going to stop and take a drink of water really quickly. While I do that, I'm going to show you my favorite bear GIF. All right. So I'm going to go ahead and switch back over to myself. And I know George has been gearing up on some of the questions. So
nothing so far.
Nothing so far? Oh, good. Well, if anybody has questions, go ahead and ask it using the orange box. If you feel like you want more detail, you can also use the green box to schedule a follow-up call. I also flashed my email pretty briefly, but it's Paige, Paige, @redoxengine.com. If you have any questions for me or any feedback too, I love feedback. If there were things you were hoping would be covered in this and things that weren't, you can reach out to me. And I'm seeing that Greg helped me with the PACS. It's the Picture Archiving and Communication System. Thanks, Greg, for doing that. Looks like we have a question about whether or not there'll be a recording of the webinar. Yep, we do provide recordings of the webinars on our site. I'm looking to George, who's our site guru. So it will be available on our site. We probably won't email it out, but you'll be able to go on there and look at it.
Yeah, so I know we also had a question about the articles that Paige linked to. So I'll send out after this the link to this recorded webinar and then also the slide deck. So you'll be able to reference those articles. Yeah, so that's one thing also. I don't know if anyone's used Crowdcast. It's a pretty slick tool where on the webinar just automatically records it, and then the link basically lives on forever to be watched. So for everyone else out there who's doing webinars, that's a little tip from Redox. So, well, guys, it doesn't look like anyone has questions or people are shy, which is fine. Just, thanks again for attending the follow-up call. If you want to talk to anyone in sales, Paige gave her email. We'll follow up to all the attendees with the slides and information, and you have a great rest of your day. As I always forget how to end it. All right, cheers, guys.